Hans Langenhuijsen. He's a consultant urologist at Radboud University Medical Center in Nijmegen in the Netherlands. And his speciality is minimally invasive surgery for kidney and adrenal diseases. His research activities focus on perioperative imaging techniques for organ-preserving renal and adrenal surgery and innovations in minimally invasive surgery. He's also a faculty member of the ESU adrenal course at the annual EAU Congress. And of course, he's the disease area coordinator for adrenal tumours in EUROGEN. We're delighted to have him here today and thank him very much for his effort and participation in the webinar series. And just very quickly, I'd like to highlight to you that EUROGEN is a network of highly specialised surgeons, and we can provide advice if you have a particular case where it's highly complex or it's rare and you would like some advice about the surgical management of a particular patient. That's possible. So please do contact us via our website, and that will be shown at the end of this. So without further ado, I thank Hans again, and I'm going to hand over to him now. Thank you very much for listening.
Okay, thank you, Michelle, for the kind introduction. Thank you, Darren. Welcome everybody to tonight's webinar. The topic for today is adrenal incidentaloma, and specifically the role of biopsies or not for adrenal incidentalomas. And although you may not consider this a very frequently incidental finding, I believe that these are more frequent than probably many of you realize. So I think it's still an important topic to discuss. So we'll start quickly, and then, as Darren already mentioned, at the end of my presentation, which is about 30 minutes, we'll have room for questions that you can put in the live chat, and hopefully I'll be able to answer your questions. So first of all, I would like to define the adrenal incidentaloma for you, and then tell you something about diagnostics in an incidentaloma. What should you do if you encounter one? And then the role of biopsies. And at the end of my talk, I have several cases to substantiate all the information I gave you until then, to show you how to deal with adrenal incidentalomas. So first of all, the definition of an adrenal incidentaloma. Basically, an adrenal incidentaloma is a tumor of the adrenal that is found incidentally by imaging. Imaging is performed for non-adrenal diseases. And in fact, this occurs in up to 7% of CT scan series. And in the elderly, it's even 10% of CT scans showing an incidental finding of adrenal tumor. And you may realize that these are mostly benign tumors. So about 80% is a benign tumor and is non-functioning, which means there's no extra hormone production by this adrenal finding. So there's a consensus that you need to have a multidisciplinary team to discuss the workup for an incidental finding of the adrenal. And if it appears that there is hormone excessive production, or it's in fact suspicious for a malignant tumor, then surgery comes into play. So my talk of today is based mostly on two clinical guidelines. As you may know, there's no urological guideline on adrenal diseases, but we have a European guideline which is endocrinology based, and it's by the European Society of Endocrinology together with ENSAT, which is the European Network for the Study of Adrenal Tumors. And the other guideline from some time ago, 2009 already, is an American guideline of clinical endocrinologists together with the American Association of Endocrine Surgeons. So these are endocrinology-based guidelines, meaning that surgery is just mentioned briefly in these guidelines. And I think there's definitely a topic for eUROGEN to provide new guidelines in the future with specific interest to surgery-related issues. There's also some consensus meetings from the Italian, Canadian, and Korean endocrine societies, and together with our clinical guidelines from Europe and the USA, these are the basis for how to treat adrenal incidentalomas. Okay, so if we look at the diagnostic workup, what do you do if you find an adrenal incidentaloma by imaging? First of all, again, it's important to realize that the adrenal is a hormonally active organ. It has an endocrine function. So you need to assess in a multidisciplinary team whether there is hormonal excess. Second of all, most important is to differentiate between benign or a malignant tumor. And a malignant tumor could be a primary malignant tumor from the adrenal, that is called adrenal cortical carcinoma or ACC, or it could be a metastasis from elsewhere. So if we go back to basic endocrinology of the adrenal, you may remember that the adrenal, as you can see on the lower left corner here, is made of an adrenal cortex. Adrenal cortex. So there's 3 layers in the adrenal cortex, and there's an adrenal medulla. The first layer of the adrenal cortex is the zona glomerulosa, which produces mainly aldosterone. Then second, the zona fasciculata, it produces cortisol. And the third layer is the zona reticularis, which basically produces the androgens, so testosterone. And then from the adrenal medulla, which has more a neurocrine function, adrenaline and noradrenaline are produced, and together with dopamine, these are called the catecholamines. So if there's something wrong about your aldosterone production, you get a primary aldosteronism. If there's too high cortisol production by the adrenal, you get a hypercortisolism, also known as Cushing syndrome. And if there's too high catecholamine productions, you get a pheochromocytoma. So it's important to realize that every patient with an adrenal incidentaloma, you have to check the patient for clinical signs of hypercortisolism. Why? Because this is a very severe disease with high mortality, in fact. And signs and symptoms of these patients are hypertension. These patients have weight gain, all kind of cerebral dysfunction like depression and psychosis. They have glucose intolerance, and on the long run, osteoporosis and easy bruising. So this is like a metabolic syndrome-like disease with very severe sequelae. And on physical examination, you will find central obesity, these typical fat pads at the neck of the patient, the pletoric moon face, and proximal muscle weakness. So in your multidisciplinary team, you discuss this with your endocrinologist, and the patient should be checked for hypercortisolism. And the screening test for this is the overnight dexamethasone suppression test. So you give dexamethasone late at night, and the next morning you measure the cortisol of the patient. And as you can see in the right lower side here in the slide, you have a negative feedback system. So if you give dexamethasone, you get a negative feedback to the hypothalamus, to corticotropin releasing hormone, which affects the production of ACTH in the anterior pituitary. And then from that, the cortisol should decrease after dexamethasone testing. If it does not, that's proof that you have hypercortisolism. And this is just a screening test. So to confirm this, you should also do either a late night salivary test for cortisol or 24-hour urine-free cortisol. So once you've proven this, you go to treatment, and if the reason for hypercortisolism is in fact the adrenal incidentalomas. So you have cortisol production from the adrenal itself. Then you have to do a laparoscopic adrenalectomy. And as you can see in this patient, after a year follow-up, this has spectacular effect on the patient quality of life, which amplifies this really very serious disease. But you have to be aware of surgery, because during surgery there might be a diminished cortisol production from the contralateral adrenal, and therefore you have to give these patients extra glucocorticoids during surgery, because otherwise they might end up having Addison's crisis during or after surgery. So this is really important. The second disease that you should definitely exclude from patients with adrenal incidentalomas is Pheochromocytoma. This is also a very serious disease with very high blood pressures. It's either continuously high blood pressure and hypertension, or it's paroxysmal, so it comes in spikes of very high blood pressures up to 300-350 millimeters. These patients have tachycardia, palpitations, and attacks of anxiety and sweating. So patients really feel they're going to die. Testing is quite simple. You have to test for these metabolites of epinephrine in the blood. So you test the free metanephrines either in plasma or in urine. Not so much epinephrine itself, because this is only comes in bursts into the peripheral blood, but its metabolite, like metanephrine, has a more stable, steady state. So this is a more reliable test for Pheochromocytoma. So if you've proven it to be a Pheochromocytoma, the treatment is laparoscopic adrenalectomy. Patients will be referred to you as a urologist, and it's important to consult your endocrinologist perioperatively, because this patient needs alpha blockade to stabilize blood pressures during surgery. And even when there's tachycardia still exists, although patient is being treated with the alpha blockade, you also need to give them beta blockade. Then the third disease, which should not always be excluded, only in a patient with an adrenal incidentaloma that has refractory hypertension. It means that he or she uses more than 3 antihypertensive drugs, and hypokalemia exists. These patients have typical complaints of muscle aches, muscle weakness, and also polyuria or polydipsia. And you may remember that aldosterone has an effect through the RAS system, so the renin-angiotensin-aldosterone system, and it has an important role in homeostasis of fluid and of electrolytes in the body by reabsorption of natrium and water in the distal tubule of the kidney, and this causes the hypertension, and excretion of potassium that leads to hypokalemia. So only these patients with hypokalemia and refractory hypertension are tested for primary aldosteronism. You prove primary aldosteronism by doing a screening test, an aldosterone-renin ratio. You should find high aldosterone and very low renin. And then finally, it's proven by a salt loading test. So these patients are giving high salt intake. And then after this salt test, you should see a decrease in aldosterone. Normally, if it doesn't decrease, that is proof for primary aldosteronism. And then, of course, this can come from your incidentaloma, so a one-sided aldosterone production, or could be a bilateral problem of the adrenal. And therefore, you can perform diagnostic adrenal vein sampling, where you sample the blood from the adrenals separately and from peripheral blood, and then you measure aldosterone values, and you can do CT scan. And if you then find a unilateral disease, then laparoscopic adrenalectomy is the treatment. If there's a bilateral problem, patients are being treated with aldosterone receptor blockers, and they end up staying with the endocrinologist for this treatment. So that's the hormonal, the tricky aspect, let's say, of adrenal diseases. Let's go to the radiological assessment. There it's important to differentiate, is this a benign tumor or is this a malignant tumor that we need to consider surgery? So basically, when you start doing plain CT scans, so no contrast is given, an adrenal incidentaloma with low Hounsfield units, meaning below 10, and a homogeneous aspect, and a small size of less than 4 centimeters is per definition a benign tumor and doesn't need follow-up anymore. So if we then look at the guideline follow-up scheme, as I already mentioned, when it's clearly benign, no follow-up is needed, but any other tumor that is larger or has specific characteristics on the plain adrenal CT scan that doesn't make it a benign tumor needs further investigation. So you discuss these patients in your multidisciplinary team. Then regularly we do adrenal CT scans, so we make a CT scan with intravenous contrast. And then we look at other characteristics, at enhancement of the adrenal incidentaloma and at washout. And the idea is that in malignant adrenal tumors, the washout of contrast is slow. It has got something to do with capillary leakage of contrast into the adrenal, and therefore it stays longer visible in the adrenal and it makes it a suspicious lesion. So discuss it in your multidisciplinary team. It could lead to further imaging like IV contrast CT scan or upfront surgery as well. And there might be cases that you consider for follow-up, and then it's advised to do a 6 to 12 months follow-up imaging, for instance, with CT scan or MRI. And after 2 years and nothing changes, you could end the follow-up. Or if there's tumor growth in your follow-up of minimally 5 millimeters per year, then you should consider every other option again. So there's some discussion. The guideline says clearly benign on plain adrenal CT scan, stop doing follow-up. There's a group from Italy, endocrinologists, who sort of make a differentiation between older and younger patients. And they say that if the patient is over 60 years, you can in fact stop doing follow-up. But in younger patients, they feel that it makes sense to do some follow-up for 2 years to see if it stays looking as a benign tumor. So then we have to discuss these patients that have signs for malignancy. So your CT scan still is indeterminate. It's not a clear benign lesion with a low Hounsfield unit and homogeneous aspect. Then you definitely have to consider it to be adrenocortical carcinoma. This is important because this is a very aggressive disease with a poor prognosis and a poor 5-year survival rate. And basically the only effective treatment for ACC is surgery. So most of these ACCs have in fact higher Hounsfield units, over 30 on your play-abdominal CT scan. That could be an indication for an ACC, and definitely washout after giving contrast is slower than normal, so below 50% after 15 minutes. So if you have these characteristics, there's still differential diagnosis. It could still be Pheochromocytoma, which has these signs sometimes as well. It could be a metastasis, but could also be still benign, a lipid poor adenoma. So Pheochromocytoma can be excluded by a laboratory tests. Metastasis, most of these patients in fact have cancer in previous history, so there's something you should consider. And metastases are quite often smaller adrenal tumors, while in my experience also the ACC tumors are mostly very large tumors, so 10 centimeters or even bigger. So besides these characteristics on your IV CT scan, there's also a size issue. We know that small tumors below 4 centimeters, the chance for an ACC is very low, 2%. So once it starts to grow over 4 to 6 centimeters, chances increase, and especially over 6 centimeters, the chance for ACC really increases up to 25%. So in general, in my practice, we keep 4 centimeters as a definitive cutoff size for an adrenalectomy. And again, as the guidelines state as well, metastasis should always be suspected in an indeterminate lesion on CT scan when the patient has a previous history of cancer. So then several years ago, there was this consensus meeting of experts in the field on how to deal with patients that have a lesion suspicious for an ACC on imaging. And because there's so little evidence on this topic, is a very rare disease. It's the incidence is about 1 in a million, but highly aggressive disease. So no really high level evidence, and therefore we had this Delphi method, and in consensus it was decided that if you see infiltration of these tumors on your CT scan, this should definitely lead to open surgery. If you have a localized tumor of 6 centimeters or less, laparoscopy is feasible and safe. It should be done by experts. And obviously oncological principles are most important, so there should always be a low threshold for conversion if needed. And also in localized tumors on CT scan imaging that are larger, so over 6 centimeters, also open surgery was advised in this consensus meeting. It's also important to do a hormonal workup in these ACCs. Why? Because many of these ACCs either produce cortisol, like in Cushing's disease, or they produce steroid precursors, also of the androgens that are being produced in the adrenal, and these patients even might have virilization. And these precursors or cortisol could in fact be used as markers, so after surgery, to warn you that there is a recurrence. And especially when the ACC produces cortisol, you have to be aware of the contralateral adrenal might be producing less cortisol due to the negative feedback, and you don't want this patient to end up with Addison's crisis after taking out the suspicious tumor. So again, you have to consult your endocrinologist and work in your multidisciplinary team for such patients. Also included in your team should be the radiologist, obviously, and interventional radiologists for biopsies. So the topic of biopsy is discussed in this meta-analysis and systematic review, which is in the guidelines as well. And it's based on 32 studies with over 2,000 adrenal biopsies. So these are very heterogeneously studies. Different needles are being used, different sizes. Mostly thin needles, 22 gauge, are being used for adrenal biopsies. And in these over 2,000 biopsies, there were about 800 cases of malignant tumors. And of these malignancies, you should know that 83% were extrarenal. So these were in fact metastases from other primary tumors. And then the most prevalent are lung carcinoma, GI tract, the kidney, and melanoma. And this is also something I recognize from our practice. For instance, in lung carcinoma, metastasizes, 25% of these patients have an adrenal metastasis. And if that's the only metastasis, it improves prognosis to take out that adrenal metastasis. So if we look at the accuracy rate of adrenal biopsies, there's a non-diagnostic rate, which is not that high, it's 8.7%. These numbers in the study were too small to conclude anything on experience or the the choice of needle size or the number of biopsies. And if we look at the accuracy for diagnosing ACC specifically, there was a fairly low sensitivity of 70%. So the chances of false negative biopsy is, in my opinion, too high. And therefore it really has no place for diagnosing ACC. The pathologist has a lot of troubles to judge the histopathology of ACC and to differentiate between ACC and a benign tumor, and then especially on a needle biopsy specimen, it's very difficult, which appears from this accuracy rate. It's a lot better in metastasis, so both sensitivity and specificity are acceptable, and therefore a biopsy should have more a place in your diagnostics when you suspect a patient of having a metastasis. So we look at complication rates, although not very high, 2.5% of these patients have a complication. You do have to realize it's still an invasive procedure, so there should be a good indication for it. And in fact, there are some patients being hospitalized for complications, not that many again, but it still happens, and even need interventions for bleedings or any other complication that you can see here in this image. And of course, there's anxiety for needle tract metastasis. This is sporadic, it's very rare, but it's being described. And especially in ACC, which is a very aggressive disease, that's something you would like to prevent. So if we look then at the two guidelines, the European and the American guidelines, what is stated about the role of biopsies in adrenal incidentalomas, the Europeans say that you should always exclude Pheochromocytoma. This makes sense because if you biopsy a lesion that is in fact a Pheochromocytoma, you get an expulsion of these adrenalins and a very high blood pressure, which in fact may be life-threatening. So you should exclude Pheochromocytoma beforehand. You could consider any lesion that stays indeterminate on your imaging. You just don't know what it is. But you should also consider that histology would actually change your clinical management before you decide to do adrenal biopsies. Then the American guideline states that, for instance, if you suspect a lesion of being a metastasis, then if pathological confirmation of this metastasis may in fact influence your oncological treatment, that you should definitely consider taking a biopsy. And this is, for instance, the case in lymphoma, where there's no first indication for surgery, but for clinical systemic treatment. So an important statement also from the guideline is that when you have a suspicion of a single metastasis and you consider this adrenal to be removed, then you should also consider doing PET-CT scan, because you want to make sure before you go to the theater that you exclude other metastases which might not be visible on your CT scan, and therefore perform PET-CT scan additionally. And also, again, as I previously mentioned, it's stated that the diagnostic performance in ACC is very low. And of course, there's this anxiety for a needle tract seeding. So therefore, it's not recommended to do biopsies when you really think of ACC. Okay, so I have 3 clinical cases from our own practice to show you clinical decision making that is being made. The first is a 32-year-old female patient that we saw with an incidentaloma in the right adrenal. You see the CT scan image over here. She was screened because of flank pain complaint. She had no medical history of malignancy or whatsoever. And she was referred from elsewhere to us because this incidentaloma grew on follow-up. It was 47 millimeters after 6 months. And also, as you can see, the plain CT scan Hounsfield unit was relatively high, so not a definite benign adenoma. And also after IV contrast, the washout was too low, clearly below 50% after 15 minutes. So in fact, a suspicious lesion. Then, as I mentioned to you, you should exclude Pheochromocytoma and Hypercortisolism, which was performed, and in fact there was no hormonal overproduction from this adrenal tumor, and therefore we saw no indication for a biopsy, and we went straight to surgery and did a laparoscopic adrenalectomy on the right hand side, and in fact our pathologist confirmed that it was ACC, also in fact with quite high aggressiveness with Y-score of 7 and a mitose index of 30%. There were negative resection margins, and at this moment we have a 3-year follow-up with this patient, and she's still without recurrence, although she's been treated adjuvantly with mitotame because of the high aggressiveness characteristics of the tumor. So my second case is a 53-year-old female with an incidentaloma in the left adrenal. She was seen by her physician because of abdominal complaints. A CT scan was performed, and then she was referred to us as a tertiary expert center for atypical aspect of the adrenal, as you can see on this image of the CT scan. Also, the basic Hounsfield units on plain CT scan were relatively high, up to 21, and it clearly had a very inhomogeneous aspect. And after contrast, there was a slow or atypical washout of contrast as well. So this could be a malignant lesion. This could also still be pheochromocytoma. So this patient was screened hormonally. From the other center, they found in fact very slightly elevated catecholamines, both methanephrine and normethanephrine. So that might in fact point towards the diagnosis of pheochromocytoma, but could also be under influence of some medication. And after stopping this medication, we again performed this analysis, and we found normal values of both methanephrine and normethanephrine. So our conclusion was it not to be a pheochromocytoma. This patient had no previous history of any malignancy, so therefore no suspicion for metastasis. So in fact, this could be a very small primary tumor from the adrenal or an ACC, and therefore we decided to do a laparoscopic adrenalectomy on the left-hand side. And we were quite surprised that the pathologist still found pheochromocytoma. So in fact, we were misled by this adrenal. It was a pheochromocytoma, so relatively indolent with very low or even normal values of catecholamines, and also no perioperative problems with high blood pressures. This patient was cured with a negative resection margin and still doing fine, fortunately. So then the third case of an adrenal incidentaloma on the right-hand side, where we did see an indication for a biopsy. This was a 74-year-old female patient with an incidentaloma in the right adrenal. So this patient was seen because of pulmonary complaints. She had a medical history, both with cardiac problems, lung problems, also diabetes and alcohol abuses, and in fact had a lung carcinoma 7 years before. She was curatively treated surgically for a PT2 lung carcinoma on the right side. And in fact, she was already dismissed from follow-up. So this was in fact a true incidentaloma of the adrenal. And if we look at the CT scan, we saw quite high Hounsfield units. So again, a suspicious lesion, and also after IV contrast, a slow washout. So clearly there's not a benign tumor here in this right adrenal. So we did further imaging with PET-CT scan, and as you may see on the PET-CT scan, also our nuclear medicine concluded that there was some enhancement of this adrenal on PET-CT scan, but relatively low, and probably also too little for metastasis. There were no other lesions found, so we were still uncertain about its origin, and that's why we decided to do a biopsy in this case. And in fact, biopsy showed that it was adenocarcinoma, and the immune profile fitted the primary lung carcinoma of 7 years ago. So in this case, the biopsy really helped us forward and changed our decision making whether or not to take out the tumor, especially as we showed no other metastasis. So this was a solitary metastasis in the adrenal from the lung carcinoma, and there is a clear benefit for prognosis for these patients. So we did a laparoscopic adrenalectomy on the right side, and our pathologist confirmed on histology that it was in fact a metastasis from that lung carcinoma with a negative resection margin. And so far, after 4 years of follow-up, eventually patient died. She got multiple lung metastases on both sides, but still 4 years later. So yeah, in fact, I think she benefited from this operation. So I would like to conclude this webinar, and then there's room for questions, obviously. To say again, I think it's very important to have a multidisciplinary team for evaluation of any adrenal disease, but also for adrenal incidentalomas. And in that team should also be a radiological expert, because you not only have to differentiate between hormonally active or inactive tumors, but also between a benign and a malignant tumor. And the role of biopsy only after excluding Pheochromocytoma. That's really important from an endocrine standpoint. And you should only do biopsies when pathology really changes your clinical management. So in fact, indications for adrenal biopsies are very, very small. And as also stated in the guidelines, biopsies should not be recommended in ACC, both because of diagnostic inaccuracy of this biopsy, but also because of the chance for needle tract seeding. Okay, so thank you very much for your attention. I think the floor is open now for discussion. If there are any questions, I'm really happy to try and answer those.
Thank you, Hans. Yeah, just waiting for questions to come in if there are any. So let's give it a second. So everyone should be able to see if you get any questions, there should be questions drop down further down on your screen, and should be able to type into them.
I should see them from the chat, right, Darren?
No, I think I need to send them on to you, Hans.
Okay,
If I'm not seeing any at the moment, so
yeah,
can't see anything in that. I think your presentation is very thorough. That's the issue. Let's give it a sec. Occasionally he's typing in very long things. I don't know. So. If anyone thinks of anything, I should say as well, if anyone has follow-up questions later on, then please email them to me. I can pass them on to Hans. Also to note that this webinar has been recorded as well, so it will be available via our website. I'll put the link on there, and also look out for future events through our website, and we also advertise this through Twitter as well, so all the information would have been you'd seen when you registered, hopefully. So one comment come through here. So.
Yeah, I'll wait for any questions. I'm really curious, Darren, if the audience recognizes the incidence of these incidentalomas, if they have them in their clinical practice, and you know, what decision making contains in these centers, and if they have this multidisciplinary approach for adrenal problems.
Okay.
I would be happy to see any feedback on those issues.
Okay, excellent. Yeah, but who's got any say about that now? So a few things come through. There's one question come through. Another one's come through here. Can you see them hands?
Not yet. I'll have a look.
There should be in questions rather than chat. So.
Oh yeah, sorry. Yeah, I just opened the wrong button. So okay, let's have a look from Reza. He's asking me why are there not new guidelines regarding this issue? That's a very good question. As I said, so there's two mainstreams. There are European guidelines and American guidelines. These are both endocrinology oriented. And I fully agree with you that, I mean, this could be a role for a EUROGEN for rare diseases. There's several things missing in these guidelines, specific surgery-related questions, whether to do laparoscopy, open surgery, and the role for lymph node dissection in adrenal cortical carcinoma, issues like this. And I mean, they're underreported in these guidelines. So I fully agree that there should be room for further development. And obviously, as a disease area coordinator for adrenal disease, that's one of my future goals for a EUROGEN to develop these guidelines with multidisciplinary experts in the field. So yeah, I couldn't agree more. There's time for revisions and time for more surgical input as well. So yeah, there's a remark from Benjamin Ayres from the UK. They have multidisciplinary approach as well in St. George's. Thank you, Ben, for your comment. That's really wonderful to hear. And as I would like to comment, if you don't have this multidisciplinary approach and you would have a case that you would like to discuss, obviously, as Michelle already mentioned, we're here for you in a EUROGEN Workstream 3 to answer questions about topics on adrenal disease. And these will in fact be discussed in a multidisciplinary setting, either locally or internationally. So there's Francesca. Thank you, Francesca, for your question. The question is for surgery, would you go transabdominally or would you consider reaching directly the retroperitoneum bilateral posterior incision? That's a very interesting question, one of my main topics. I'm very much a fan of retroperitoneoscopic surgery, but let me just comment on this, that I consider that specifically suitable for smaller benign tumors. So for instance, in the primary aldosteronism patients, these patients obviously have small benign adenomas producing aldosterone. Mostly they're under 2.5 centimeters. And then in a patient with, let's say, BMI below 35, that would be a clear candidate for a retroperitoneoscopic approach, in my opinion. And if the tumor is larger, so over 6-7 centimeters, or there's a suspicion for malignancy, especially in ACC, I would not go for a retroperitoneal approach because there's clearly a space issue there. You have a higher chance of disrupting the tumor. That is something you definitely don't want to do in an ACC because you have one chance that is a good and radical operation. So I would go for laparoscopic approach, or even in case of a bigger ACC for an open approach. And then we normally do a transabdominal subcostal approach, quite often also with the liver surgeon for full liver mobilization on the right-hand side to have the best exposure to do a radical operation. So yeah, I like a differentiated way of looking at surgery. I prefer retroperitoneoscopy because it definitely has some advantage for the patient's recovery. But from an oncological perspective, you need more space. You need the peritoneum to work and to do a proper oncological operation. So if I may, Darren, there's still another question about mentorship program from Sahil. Thank you, Sahil, for your question. Yeah, we do have like adrenal training program locally in our center. We can set it up, obviously, for you. And, you know, you could come over and we'll have many cases to do. In fact, locally, we have around 70 up to 80 laparoscopic cases per year. So it's definitely possible to do cases together, or even have a mentorship, as you call it, or a tutoring on site in your hospital as well.
Okay, can you see the other question as well, Pascal?
Yeah, Pascal, there's one coming in from Pascal. And the question is, what is the upper limit for laparoscopic approach in your practice? And in the absence of infiltration on CT scan. So, okay, you talk about a localized tumor, but probably, as I understand from your question, a suspicious lesion for an ACC. So from our consensus meeting, we decided that 6 centimeters should be the upper limit. And in general, I believe that is a good advice. So up to 6 centimeters, it's safe and oncologically safe to do a laparoscopic approach. On the other hand, you need to acknowledge that you need experience to do this. So we defined it as minimally 15 laparoscopic adrenal operations per year in this consensus meeting. Honestly, I go a little bit further. I might consider 7, 8, or even 9 centimeters to be feasible as well, as long as there's no infiltration, because I believe that if there's clear infiltration, you should go for open surgery, not only to do a good oncological resection of the tumor itself, but to do a full lymph node dissection as well, which has limited value in terms of prognosis for ACC patients, but definitely has a meaning for staging of this patient. So yeah, with a larger tumor, definitely with infiltration, I believe there is an indication for lymph node dissection, and this obviously is much more feasible with an open approach. Okay, I see one more question from Reza. Is there any indication for MRI as a diagnostic imaging, except for sensitivity for iodine? Yeah, that's a good question. I mean, it's locally dependent. We do primarily CT scans, and I'm also very safe with looking at these CT scans myself, besides the radiological expert. MRI is somewhat more difficult for a urologist to judge, obviously, but it's very locally dependent, I believe. There's quite a lot of centers who do MRIs for adrenal disease. We're used to CT scans, but if there is a iodine sensibility, obviously you could ask for MRI, and I think the accuracy or the diagnostic value of MRI is at least compatible to IV contrast CT scan.
Okay, so everyone else got anything else they want to ask? Got a few minutes left until 7 o'clock. So, like I said, if anyone thinks of anything afterwards, then please don't hesitate to email me. I can pass the emails on and get an answer. Let's give it 1 more minute, Hans. It's okay?
Yeah, sure.
I'll email
I'm
out
still-
to everybody. Sorry, go on. Yeah, sorry.
Well, I was still curious about how the audience thinks of this hormonal evaluation in every adrenal incidentaloma. I think it's not very widely known that you should do this according to these guidelines. Is there someone who wants to comment on this? Do you always consider your endocrinologist to do this hormonal evaluation in every incidentaloma you find? I'm curious about that.
Okay, not got anything else coming in. Hopefully some people might come out afterwards, and there'll be, so we're recording this, so there might be questions, hands as well from people watching the videos.
Yeah, sure.
Well, so I can try and put that on.
Happy to answer them later as well. Yeah, most welcome.
If you want to formulate those questions, if just those things you're interested in, actually, and send them to me, I can maybe somehow attach them to the video so people can know that you're asking for what you're interested to know their opinions. So that would be good.
Yeah.
Cool.
Great.
Okay, so I think given us 2 minutes to 7, let's call that day there. And thank you very much, Hans, firstly, for presenting that. It was very interesting. And thanks, Michelle, for the introduction. And thank you to everyone who attended as well. So this video will be available afterwards. And look out on our website and Twitter for our future events. We have got one planned for June. It's in on June 16th of June. I will put the details of that on the website very shortly. They're not on there. I don't think. I'll do that tomorrow. So yes, thank you very much, everyone, and take care. Thank you.
Okay. Thanks, Darren. Thanks, Michelle, for organizing, and thanks everyone for watching. It was a pleasure. Thank you very much.
Thank you all. Bye.
Bye-bye.